Sometimes we're confronted with a chief complaint that's at the same time vague, but potentially dangerous. Common, but possibly with consequences, if not identified or treated, or just plain frustrating, because there doesn't seem to be any clear path to risk stratification, diagnosis, or management. Now, we could be talking about any one of the many challenges we face in the ED, but let's tackle a common but time and energy-consuming presentation. Headache. A little relief from me to you.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Headache in children can be as complicated as we make it. Let's break it down to what we need to know now and what parents need to know when they go home. Primary headaches, headaches with no sinister secondary cause like tension or migraine, are, of course, diagnoses of exclusion. Today, we'll focus first on secondary headaches, the headaches due to something we need to know about now. Then, once we've established safety, I'll offer some advice on how to help the child and family with the more common, benign presentations. All right, let's talk secondary headaches, because really that's what we're here for. And not surprisingly, that's what the parent is usually here for. Often parents are deathly afraid that their child has a tumor, for example. As we know, the differential diagnosis for headache is vast. But take heart. Your careful history and physical exam will point you in the right direction. The mega list is in the show notes. If we listen to the patient and family, if we think multi-system, and we're our normal, careful selves, we'll be all right. But sometimes the story is just not so obvious, and we leave the exam room with our doubts. There are three main questions that sometimes linger. Is it a tumor? Is it an infection? Or is it a bleed? Is it a tumor? A few things in the history will help us. What we're trying to get at here is, are there detectable signs or symptoms consistent with a space-occupying lesion? Here are a few high-yield red flags for headache caused by tumor. Progression and worsening of symptoms over time. Associated vomiting. Pain only in the occiput. Headache that's worse with Valsalva. Ask if coughing, urinating, or defecating affects the headache. Does the headache wake the child from sleep? Is it worse in the morning just after getting up? Conversely, the absence of some historical features may actually worry us more. No family history of migraine. No associated aura with the headache. It's difficult, right? Truthfully, no one is very good at explaining his own headache symptoms. Children are no exception. Do your best to have the child speak for himself as much as possible. If he can draw his symptoms on a piece of paper, go for it. Sometimes their headache artwork can be revealing, or it can at least be a good start. The typical tumor scare happens in a child with recurrent headaches. The parents have tried what they can, and they're baffled by the recurrence. Dr. Google makes an entrance, and well, we all know the rest of that story. What I'm getting to is this. Who needs neuroimaging? The short answer is, if the child has an abnormal exam finding, then get a non-contrast head CT in the ED. Take the time to do a thorough examination, especially looking for cranial nerve findings, gait abnormalities, or differences in strength. In older children, coach them through your exam to check their fundi. If you're worried enough to get imaging, then you should not feel great about sending him on an expedition to MRI. The most common brain tumor in children is astrocytoma, and thankfully most are low-grade gliomas, which are indolent. They're slow-growing tumors that present in children ages 5 to 8. The most common type of malignant primary brain cancer in children is medulloblastoma. Most occur before age 10. The reassuring point is that for a child with a normal neuroexam, we have time to figure this out. For the recurrent headache, outpatient MRI really is the way to go if at all possible. Not only do we forego unnecessary radiation, but MRI is more likely to identify a potentially serious cause or rule out the concern. Medina et al. In Pediatrics reported on children with headache suspected of having a brain tumor. They stratified patients into low, intermediate, and high risk based on clinical predictors from the history and physical. All had imaging. The researchers then calculated probability of tumor in each group. The low-risk group had a 0.01% probability of tumor. The intermediate group, 0.4%, and even the high-risk group had only a 4% probability of tumor. The high-risk features were the one we just mentioned. In other words, ask the high-yield questions and know that you have time on your side in the stable patient with a normal neurologic exam. Here's what the American Academy of Neurology concludes in their most recent guidelines, published first in 1994 and revised in 2004. There are 3 of them. 1. Neuroimaging on a routine basis is not indicated with recurrent headaches and a normal neurologic exam. Score. 2. Neuroimaging should be considered in children with an abnormal exam. Okay, we're still on board with this. 3. Neuroimaging should be considered in children with recent onset of severe headache, change in the type of headache, or associated features that suggest neurologic dysfunction. Okay, makes sense to us, right? Use your best judgment to assess the urgency of the matter and look for other things that are not tumor, like infection or bleed, which brings us to, is it meningitis? Now, you got this. If you think you need to perform a lumbar puncture, then you're right. Go after the diagnosis when it meets your threshold for testing. What I'll focus on now is not the toxic child or the one with meningismus, but the child who just has a headache, plus or minus symptoms that may be viral syndrome. These, in a way, are tougher because it's perfectly normal to have a headache with a fever or a virus. It's just not normal to have a CNS infection. So how can we distinguish the two? In short, it's difficult. Dr. Curtis et al. In Pediatrics did a systematic review titled Clinical Features Suggestive of Meningitis in Children. As far as the history is concerned, just the obvious stuff panned out, like bulging fontanelle in the infant or neck stiffness in the older child, both of which increase the likelihood of meningitis by 8-fold. As far as physical exam goes, really the only reliable predictors were poor general appearance or a change in behavior. In other words, you would have caught those cases because you would have tuned into meningitis early on, especially in the unvaccinated crowd. So, what about fever and headache? Even the presence of a high fever, so greater than 40 degrees Celsius, only conferred a positive likelihood ratio of 2.9, which is only marginally predictive. The nice thing is that for temperatures less than 40 degrees Celsius, the likelihood ratio was 1 for meningitis. In other words, a fever less than 40 degrees was just as likely to be present with or without meningitis. The way I look at it is this: for the headache-only child with a normal physical exam, and you weren't impressed with the whole meningitis thing, you're in good shape. Add a low-grade fever to the otherwise well child, and you're still likely to be fine. Maybe a higher fever adds to your concern, but now I'm going to stray from the evidence and just give you my opinion based on experience. If it's the fever causing the headache, then take away the fever and see how the child is. I'm pretty sure NSAIDs are not bactericidal. In the otherwise well child for whom you have a low suspicion, it's perfectly fine, in my opinion, to treat the symptoms and reevaluate. So now, is it a bleed? When we talk about the risk of hemorrhage or clot, the first question is, does this child have some underlying disorder, like sickle cell disease, hypertension, rheumatologic disease, or some other endocrine or metabolic disease like mitochondrial disorder? In chronically ill children, think about cerebral sinus thrombosis, vasculitis, ischemia, or hemorrhage. Again, you'll be alerted to the possibility of a complication and you'll do the right thing using your best judgment for the child in front of you. It's the otherwise well child with a headache that may leave some nagging doubt, especially if the parents are very anxious. They may be right, but you're thinking, well, it doesn't seem to be a chronic space-occupying lesion, and it doesn't seem to be an infection, so is it a bleed? The de novo bleed that is most on our minds is an arteriovenous malformation. The understanding of AVM is dark and full of terrors. We really don't know enough about AVMs in the brain to say what is the typical presentation. They may be completely asymptomatic until they rupture. Even the headache presentation is variable. Just reflecting on the cases that I've seen or have been involved with and scouring the literature, I can offer some commentary. Although AVM may just look like any other headache, to me, it's usually one of those headache plus presentations. That is, headache plus some other worrisome finding or feature. New headache plus vomiting. New headache plus it's unilateral. Headache plus a new seizure. Headache plus focal neurodeficits, which may be transient due to a vascular steal phenomenon. What I'm saying here is these are rare presentations, but they often have some red flag associated with them. For what it's worth, in all of the cases that I know of or heard of or read about, there is something else that is worrisome about the headache. Although an AVM is a ticking time bomb, I sure hope the next time I see one, it resembles the others. A headache plus. Something else is usually going on. If you listen, you can hear the proverbial hissing of the fuse after it's lit. And hopefully we extinguish it before it goes off. Just to illustrate the presentation of an AVM, 2 quick cases. Number 1, an 11-year-old girl presents to the ED with new headache, nausea, and vomiting in the morning, and she stayed home from school that day. Later on in the afternoon, she had a generalized seizure and was brought in by ambulance with a low GCS. She was intubated to protect her airway, and CT confirmed the AVM. She had a right frontal intraparenchymal bleed with midline shift. She underwent clot evacuation and extirpation of the rat's nest of intertwined arteries and veins. A second case, a 9-year-old girl presented to the ED with headache for 2 days that was constant and severe. She really hadn't suffered from headaches in the past and was treated initially at home with over-the-counter medications. On the day of presentation, she developed nausea and vomiting. On arrival, she was altered and had slow-reacting pupils. This girl also underwent evacuation, and only on histopathology did they find a single arterialized vein. Now, there are times when AVM is picked up on an asymptomatic patient, as in an MRI for another reason or a trauma scan. If this child is referred to me or he's in my ED, he's getting admitted because we just don't know what to do with these asymptomatic children who are almost guaranteed to bleed at some point. They need an urgent intervention or at least a rock-solid plan to go further. So when we talk about headache and the question of clot or hemorrhage, it's reassuring to know that there typically is something else pushing us to investigate emergently. This is not the otherwise well child that appears to have run-of-the-mill headache. Alright, now that we've addressed the risk for a dangerous secondary headache, and we're feeling comfortable that this is a benign primary headache, or perhaps this is another exacerbation of a chronic presentation, what now? The two main types of primary headache in children are just like those in adults: tension and migraine, with a few twists, of course. There always has to be a catch, right? Tension headaches are the most common in children and adults. Just like in adults, tension headache is band-like pressure, tightening, and often associated with muscle aches in the neck and shoulders. Find out how often they occur and whether there's any pattern of worsening symptoms, or if the symptoms seem to be related to sleep hygiene, to video games, to too much digital screen time. Also, screen for lack of exercise, poor diet, stress, and all of the other good questions you usually ask. Treat the symptoms, try to find out the contributing factors, and counsel the family about lifestyle modification. Offer PO hydration and an NSAID like ibuprofen or acetaminophen or paracetamol. Non-pharmacologic techniques are excellent adjuncts. They help to treat the whole person. Think about recommending heat packs or rest or stress relief, and of course, sometimes just a little TLC. A brief note on the psychosocial aspect of headaches. Be careful not to encourage overreacting to the headache. Sometimes we see a pattern of headache, attention, and more headache that can take root. The child has real pain, but it can be amplified by his or her environment. Get a sense of the parent's reaction or response to the child's symptoms before you start offering some advice. Listen some more, and look for areas where there's room for improvement. Also, look for overuse of medications, which may be the culprit in up to 50% of chronic headaches. Well-meaning parents may be giving NSAIDs 3 or more times per week, which is associated with medication-induced headache, or if you want to get fancy, cephalalgia medicamentosa. We've talked about tension headache, the most common primary headache. Cluster headache is extremely rare in children. That leaves us with another big primary headache syndrome, migraine. Honestly, in general, I think we have a little mismatch between how we see them and how patients and families see them. Self-diagnosis of migraine is rampant. In the vernacular, any bothersome headache is labeled a migraine. To us, this word has specific meaning and treatment. But on the other side of the coin, we often fail to identify migraine headaches in children, especially in the ED. I think this is for two reasons. The prevalence of migraine increases with age, and children just don't present exactly like adults do. Our understanding of migraine pathophysiology is still evolving. Traditionally thought of as a vasospastic phenomenon, current thinking is that it's a sensory processing disorder affecting the trigeminal nerve and its nucleus, as well as the trigeminal-cervical complex and brainstem modulation. Migraine sufferers exhibit a strong inherited component. Stewart et al. In neurology report an increasing prevalence of migraine with age. In children 3 to 7 years of age, 2% had migraines. In those 7 to 11 years of age, 7%. And migraine was found in 20% by ages 11 to 20. Here's a way to remember: 3% by 3, 7% by 7, and 20% by 20. Not exact, but ballpark based on the study. The point here is that migraines in children are more common than we may expect, and they can interfere with school performance, with social development, or even with family dynamics and overall stress burden. So, how can we make this diagnosis? Not to burst your bubble, but we often don't. The International Headache Society's diagnostic criteria for migraine headache in children vary depending on the presence or absence of an aura. The punchline is that aura gets you a fast pass to a migraine diagnosis. If the child has 2 or more attacks with aura, you have your diagnosis. Auras can be visual, sensory, affecting speech, motor function, or can be brainstem or retinal. Migraine without aura is more involved. The criteria are similar to those of the adult, and there are 4 of them. Number 1, headaches lasting 2 to 72 hours, treated or not. 2, headache with 2 of the following: unilateral, pulsating, moderate or severe intensity, or aggravation by physical activity or avoidance of physical activity. 3, during the headache, 1 of the following: nausea or vomiting, photophobia or phonophobia. And 4, finally, they need 5 or more of this type of headache to make the diagnosis. A key point to remember here is that children with migraine more often present with bilateral headache. When we normally hear bilateral symptoms, sometimes our minds go to tension headache right away. Try not to be dissuaded from the right treatment just because it hurts on both sides. So you can see the criteria are involved and require multiple episodes to make a good diagnosis. We may not know for sure if this is migraine or tension headache in the ED, and that's perfectly fine. We should know about the criteria, however, because it's important for us to recognize when the chronic headache is not a migraine. Also, it's important to be aware of some disturbing presentations that may end up being variant migraine. There are some migraine syndromes that tend to freak us out. Basilar artery migraine is an aura migraine that happens more often in girls. Along with a headache, she may have dysarthria, tinnitus, diplopia, decreased level of consciousness, vertigo, or ataxia. It can look just like an AVM or tumor. Basilar artery migraine, for us, is a diagnosis of exclusion, and these girls get admitted for an MRI to establish the diagnosis and to cool our jets. Ophthalmoplegic migraine is rare and associated with cranial nerve findings, especially cranial nerves 3, 4, and 6. Again, this patient is getting a stat CT, and when there is no other explanation, he's getting admitted for further workup. Another variant migraine that requires some careful history taking is Alice in Wonderland syndrome. It presents predominantly with sensory distortions of objects that make them appear larger or smaller than they are. Visual distortions usually start before the headache. Acute confusional migraine is just that, an altered mental status associated with headache that may include agitation, lethargy, or aphasia. These may look like the dramatic person with a headache or even a drug overdose. Another warning for us not to brush off the dramatic or confused or erratic teenager. How do we treat primary headaches? If you feel this is a mild tension headache, then fluids by mouth and a simple NSAID are probably all that's needed, in addition to a heaping dose of reassurance. The moderate to severe headache may just be a bad tension headache, or it may be a migraine. We can start with the basics and escalate from there if needed. We have the best evidence in children for ibuprofen, but acetaminophen is probably just as effective. Abortive treatments with the triptans may have been tried at home, but if they're coming to see us, we're past the point where triptans will be helpful. So what do we do now? For the primary headache that's resistant to NSAIDs, especially if it's probably a migraine, a lot of our evidence basis for ED treatment of headaches in children is extrapolated from the adult literature. For the truly suffering child, we're talking IV therapy. If you're going for IV, a nice evidence-based migraine cocktail is the following. 1. A bolus of 20 mL per kilo of normal saline, up to a liter. 2. Ketorolac, 0.5 milligrams per kilogram with a max of 30. 3. Diphenhydramine, 1 milligram per kilogram with a max of 50 milligrams. Prochlorperazine, 0.1 milligrams per kilogram with a max of 10 milligrams. Dr. Carr et al. In Pediatric Emergency Care evaluated the safety and efficacy of their institution's standardized pediatric migraine practice guideline in the emergency department, which used this cocktail based on the best evidence available. In their retrospective chart review, they found the average visual pain scale dropped from 7.8 to 2.1. There were no adverse events reported. So really, you can treat children with migraines very similarly to adults. For everyone who is going home, take just a moment to talk about the importance of sleeping well, of eating well, of getting good exercise, limiting digital screen time, and trying to improve ways of dealing with stress. Children with undiagnosed anxiety disorders may present with recurrent headaches. When all else fails and the parent has heard it all, one thing that I find helps is to get them started on a headache diary. Take a piece of paper, fold it in half, and start a template for them to work on in a spiral notebook at home. I start a sample entry for them with the date and the time the headache started, what it felt like, and what was happening just before, what made the headache better, any dose of medication given, and how long it lasted, what the child did afterwards. This, by the way, is the first thing a neurologist will start them on. And it's sometimes a selling point to the parent that the time spent waiting for a referral to a neurologist is not wasted. They'll actually be in better shape and can move things forward faster. It also gives them some sense of control over what can be a draining situation. Okay, a quick summary by way of mental algorithm. If you are thinking meningitis, especially with fever or nuchal rigidity, get a CT first if you see signs of increased intracranial pressure or an abnormal neuro exam. Otherwise, go straight to LP. In the afebrile child with a normal exam, give symptomatic relief, briefly counsel them, and have them follow up. In the afebrile child with an abnormal exam, get a CT in the ED. If negative, either admit for MRI if you're still concerned, or consider LP for pseudotumor cerebri. Not to make it too simple, but those are the high notes for us. For everything else, you'll pick up something on history or physical exam for any of the long list of the differential and go towards that. Talk with parents early about expectations and offer them some friendly advice on prevention. Refer patients to the primary care provider or neurologist if the presentation is more involved. After a good history and physical examination in the ED that results in no red flags, we have time on our side. Help the family through the process by explaining the next steps and what can be done in the meantime. Compassion and a plan. Sometimes these are our most powerful allies. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.